Hi, well, welcome everyone. My name is Tina Domer, or my licensure is Kristina Domer, but I've been working with hospice now for about 9 years, maybe going on 10 years in this capacity as nurse liaison. So it's great to be in front of people again and to see people and to see your faces and to talk about a wonderful program like our Altman Hospice and Palliative Care. But I'll be talking in general about palliative care and hospice, and you'll go away with a better understanding of what palliative care and hospice is and is not. So this presentation was originally created by Dr. Lair. She's our medical director for hospice and palliative care out of the so she does, of course, a fabulous job. So I was lucky that she passed it along to me. Okay, so we're going to start with palliative care. So palliative care, it's relatively new, specialized area of medical care. Probably, I don't know, you guys probably started hearing about palliative care over the past 7, 8, 9 years. It now has a fellowship training program. And of course, you can become board certified for our physicians. Some of our physicians at Altman Hospice and Palliative Care who work for Altman and for the Hospice Palliative Care program are board certified in hospice and palliative care. So definition of palliative care, what does it do? It is a specialized medical care for people with serious illness. The focus is on relief of symptoms, pain, and stress. And the goal is to improve quality of life for the patient and the family. So who are our team members? We have physicians, nurse practitioners, social workers, chaplains, and nurses that all see our patients through palliative care. So what is the goal of palliative care? Our main goal is to create a plan of care that gives you the best quality of life you can have at home or wherever you call home. And we'll get into where our palliative patients are later, but it's a plan of care for patients that involves their complex medical problems. And it's symptom management. Those symptoms, so it keeps you out of the emergency room. It keeps you from multiple phone calls to your primary care physician. It keeps you from, hospital. So we're going to manage those symptoms at home for you. So we have a specific goal. Our goals are specific, and that's what's nice about palliative care because our physicians, our staff really take the time to sit down and talk about your disease process, talk about where you are in that disease process, and really nail down some goals that are going to improve your quality of care. They're measurable, so we know that we're achieving what we need to achieve. We make sure that they're achievable, that they're realistic, and that they're timely. You can put them into effect. So that's our plan of that's all nailed out in our plan of care for each patient. So palliative care can be initiated while the patient is still seeking curative. Okay, so that's something different from hospice. So, hospice, you can't be seeking curative aggressive treatment. And also palliative care is for when a patient has chosen comfort care, but is not quite ready for hospice. They can come into our palliative care program. So how does our team work? So our team talks with patients and their caregivers, significant others, family members, whoever is there providing care for them or part of their life that they want involved with their care. And they really hammer out that plan of care that I was talking about. And they set both short-term goals and also long-term features they handle right now to make sure that when you go home, you're prepared for whatever symptom arises, whether it's shortness of breath or pain or anxiety, and also long-term goals, where do you want to be 3 months from now, 6 months from now? So to sit down and do this with you. So sometimes it's appropriate to discuss prognosis. So our prognosis, if there's a life expectancy that really needs to be discussed, not always, but sometimes if that's appropriate, our doctors will discuss about prognosis. Sometimes it's just a chronic illness that you just need to get back to your normal self, and sometimes it's not. So of course that's all taken into consideration when our physicians sit down and talk to you. So the team also offers information on and assistance in completing of advanced directives and living will. So talk a little bit more about this. This could be a whole other topic. I don't know if you guys have advanced directives or living wills or DNRs, but literally that could be a whole nother presentation. But they take the time to explain these documents to you and help you fill them out. So the team provides emotional and spiritual support and comfort. I can't tell you how many times I've had family members, especially in hospice, but also in palliative care. They're so thankful for the support offered not only to the patient, but to the families. So it's everyone involved. It's not just the patient to take care of. They consider everyone involved. All right, so how does a patient get into a palliative care program? Well, typically at Altman, we have a really robust palliative care program. And we use a screening tool that determines patients who might benefit from palliative care consultation. And then we have, of course, then palliative care consultation comes in and they consult, usually, in addition to a hospital referral, a consult usually is requested by a attending physician, but it can be requested by a patient or a family member or even a nurse. I guess my best advice is if you have questions and you think they're appropriate for palliative care, ask, because so often patients and family members wait until it's too late and they could have been receiving all of our benefits earlier. So my best advice is to, if you have any questions, call our hospice office. And I'll give you the phone number now, and I'll give you the phone number at the end of the slideshow. So we have 2 offices, Alliance and Canton. Our Alliance is 330-596-7480. And then our Canton office is 330-479-2378. I can tell you how important it is for community members to reach out to us. Part of our job is educating you guys, and we want you guys to be aware of the services we provide. So when in doubt, just give us a call. So as far as palliative care and our visitation and how we see patients, it's really determined by what's going on with the patient. So the patient gets followed at regular intervals to provide continuity of care for the patient. So again, that's based on a lot of, it's based on comorbidities, which means diagnosis in addition to the diagnosis that brought you may have pneumonia, but you may also have Parkinson's and diabetes. So the more comorbidities you have, the more likely it is that you're going to have a harder time recovering. So it's really a combination of the assessment, your comorbidities, and then they develop a plan of care right then and there for how often you'll be seen or called or both. It's really patient-driven, and it's really whatever the patient needs. Okay, so our palliative care services, I talked about our hospital consultation service. Like I said, we have, they're very busy over in the hospital there that these patients. We also see patients in the clinical and in certain clinical areas such as oncology and cardiology. Age congestive heart failure or cancer patients that are, having lots of side effects from medications or are just debilitated in general from their treatment. So our palliative care services are embedded in those clinics. Also, patients in nursing homes, we see patients in their homes, and so it's billed differently from hospice in that the visits are billed just like a regular doctor visit. So just like you would go see your primary care physician, if our palliative care physician came and saw you, they would bill just like the primary care physician would bill. Okay, so the value of palliative care. Well, first, the quality of life. Research shows this. The quality of life is drastically increased because we are keeping patients out of the emergency room. We are keeping the patients out of or decreased hospitalization stays, and we are teaching them and their family, whoever their caregiver is, manage their symptoms at home. And we're teaching them how to do that so that we can, sorry, just gonna, oh, wait a minute, let me get rid of this pop. So it really, primary provider, what's the value to your primary care provider? So our physicians, our palliative care and hospice physicians work with their provider, but it also saves them time. So you're not constantly calling the physicians off your primary care, with problems associated with symptom management. Hopefully our palliative care team can teach you to do that at home, and they'll be able to help you through that too. So the values to the overall health system. Well, it provides better continuity of care, and it provides better care coordination. You have one more set of eyes watching them manage their symptoms and keep them out of the emergency room and decrease hospitalizations. And that, of course, leads to cost savings because, it costs lots of money to go to the ED, to the emergency room, or for hospitalization. So again, our goal is to keep you out of the hospital, out of the emergency room, give you better quality of care. And it's been proven to do that. Okay, so here's an example. So we have a 67-year-old patient with chronic obstructive pulmonary disease. He's short of breath at baseline, which means when he's sitting there doing nothing, he's short of breath. He's independent on oxygen. He's on 16 different medications for various problems. He sees 4 doctors, and he's very anxious. He has not completed his advance directive. She and her family do not understand her diseases and her prognosis. So how's palliative care going to help this patient? So immediately they would consult and relieve those symptoms. They would look at medication and ways to help him breathe better and decrease his anxiety. One nice thing also is the medication review. When you have another set of eyes, a physician looking at those medications. And remember, this is their specialty. So they're looking at these medications from a different angle. Like maybe you have a medication that isn't working like it used to, or maybe you have medication that's causing some of the symptoms of anxiety or your shortness of breath. So they take a look at that and they suggest changes to your primary care physician. They educate patients and family on the prognosis. We talked about that. And using all patient information available. So they really educate the patient on, on his medications and his disease prognosis, or his diseases and the prognosis, because they don't understand why he's, constantly short of breath and why he's anxious and, typically what's worked in the past isn't working now. And so they're going to talk you through that and explain why. And then they're going to fill out his power of attorney for healthcare, his living will, and a DNR if appropriate. So again, I'm going to touch a little bit about these. Like I said, this is a whole other presentation, but power of attorney for healthcare. So that is someone that you assign that will speak for you when you cannot speak for yourself. Okay, it does not override your living will, and it's very important that whoever you assign for your power of attorney understands your wishes, because that's their job, to make sure that when you are unable to speak for yourself, that they can speak for you, making your wishes known when you can't. So it's important that that you assign someone that knows your wishes and that will carry them through for you. Okay, and then of course a living will, I think, is pretty self-explanatory. And then a DNR. So a DNR is a do not resuscitate order. It's for when people have decided that they don't want to be revived when their heart stops and when they stop breathing. It is a physician order. It's something that you need to discuss with your physician and decide on the appropriate DNR orders. CHF, congestive heart failure. So we have an 80-year-old male with advanced heart disease, a weak heart with multiple episodes of hospitalization over the past year due to congestive heart failure. He and his family can't understand why the doctors can't get the medicines right and why he is so weak. He is tired and not sure if he wants to. There are a couple of things in here that kind of are a red flag. Of course, your multiple episodes of hospitalization over the past year, but also this phrase, can't get medicines right. So often people are appropriate for palliative care and for hospice when medicine is not effective for them anymore. So when all of a sudden you have medications that have worked, and then all of a sudden they don't, and the physicians can't get you regulated. Red flag. You need to really consider palliative care and maybe even hospice. So they're going to do a palliative care consultation, would assist with symptom management, of course, and using medications for their shortness of breath and anxiety. And then again, they're going to really educate the patient and the family on where their disease process is. How advanced is it? Are we nearing, a discussion of, do you want to go back to the hospital? So that's what they're going to talk about as far as understanding the progressive nature of the disease. And then again, they're going to take a look at your goals, and they're going to make sure that they're achievable, that they're realistic, that you can do them. They're timely, they're manageable. So they're going to take a look at that too. All right, dementia. This is my last example. So we have a 76-year-old man with advancing Alzheimer's dementia who has had episodes of pneumonia in the past 3 months. Doctors have said he can't swallow properly, and the family is unsure of what to do. Do they consider a feeding tube? Do they want further hospitalizations for their loved one? So the palliative consultation would be important to help counsel and educate family regarding the progressive nature of dementia. So dementia is a progressive disease. There's no cure for it. It just continually worsens. They're going to discuss the pros and cons of a feeding tube placement. They're going to discuss, the pros and cons of further hospitalizations for the patient. Is it really benefiting him? For his recurrent pneumonias versus conservative care at a nursing home. And again, those goals of care for the future that are realistic, that are timely, that are manageable, that everyone understands. Okay, so summary of palliative care. It's a multidisciplinary team dedicated to assisting patients with chronic disease and symptom management. It improves the quality of life, and that's what we want to do. We want to improve your quality of life. They take lots of time educating about the disease process, your prognosis, if appropriate, and they really define those goals of care. What are you going to do when you get home and you become short of breath? What are you going to do when you have an increase in pain. Like, who are you going to call? What, to keep you out of the hospital and to keep you from multiple phone calls and visits to your primary care. All right, hospice and compared to palliative care. So hospice is a hospice benefit. So most insurance companies have what they call a hospice benefit, and there's a lot more involved in hospice care. There's a lot more benefits involved in hospice care, and you'll see that as we go through it. So hospice care is provided by a team very similar to the palliative care team, and often maybe the same physicians and nurse practitioners, but we have our doctors, our nurses, our nurse practitioners. We also have home health aides that go out to the home. We have social workers and clergy both at palliative care, but at hospice, it's required that you have a volunteer program. And a volunteer program is wonderful. They're wonderful people. They do so many different things. They will go into a home and sit with a patient. They'll read to a patient. They might do some light cleaning. They might, anything that patient needs that they are unable to do at that time in their home, they can do that. Some volunteers will go pick up medications at the pharmacy. They're really invaluable. And I really enjoyed getting to know a couple of them working through the hospice program. But they are, like I said, it's required for every hospice to have a volunteer program, and we use them for multiple things. And so maybe not even going out and seeing a patient, we also use them behind the scenes in the office, clerical, helping with fundraising. They have multiple uses, and we're so thankful for them. And then also patients can still see their primary care doctor if they desire, but you will have a hospice physician that oversees your hospice care. So our hospice physicians are more than willing to work with primary care physicians, but you will have that hospice physician overseeing your hospice care. Okay, so hospice services. So hospice comes to you wherever you call home. If that's in a private residence, if it's in a nursing home, assisted living, if it's with a relative, wherever you call home. Okay, so the patient is no longer going to go to the emergency room. The patient is going to no longer go to the hospital. Our staff, our physicians are highly trained. They're experts at doing this, and they provide your care wherever you're at. Services are provided in the patient's home or nursing facility. Most insurance plans will cover all of hospice care. And this is another huge benefit that's different from palliative care. So when you're appropriate for hospice will pay for all the necessary drugs that are related to your terminal diagnosis, okay? Which can be a huge financial relief. They also pay for any medical supplies related to your terminal diagnosis and any medical equipment related to your terminal diagnosis. So financially, that can help a lot of people out. Palliative care does not have those benefits as far as paying for medications, medical supplies, and medical equipment related to your terminal diagnosis. All right, so patient population. So what does a hospice patient look like? Person diagnosed with a life-limiting illness with a prognosis of 6 months or less to live. So I've been out there talking to the community long enough to know that some hospices can be a scary word with people, and sometimes people get hung up on this 6 months or less to live, and and you have to understand that it's just an approximate. It's not set in stone to live. So they have to base how you qualify for hospice on end of life terminal diagnosis. We have patients who are in our program a lot more than 6 months. We have a patient that are in our program a lot less than 6 months. So that's just don't get fixated on that number, because it's it's not like every patient at 6 months was saying goodbye. Our patients, it's required by law that Our physicians recertify and reassess our patients on regular intervals to make sure you continue to meet the requirements for hospice. And as long as you meet those requirements for hospice, you will remain in our hospice program. So it's all, like I say, individual. It's based on our, just like our physician admitted you based on certain criteria. They do that throughout your stay, and they do this using criteria based on the patient diagnosis and the patient functional status to determine the prognosis. Okay, a patient may receive hospice care for as long as necessary when a physician certifies that he or she continues to meet hospice eligibility requirements. So that's what I was saying. So you have initial assessment that's done by the physician, and then the patient gets recertified after 90 days. And then after that, they have face-to-face visit, recertification of 180 days, and every 60 days thereafter. So what the insurance companies are just making sure is that the patient continues to meet qualification for hospice. So that's why our physicians do that. So Hospice Services, we focus on caring, not curing the illness. And the goal is to improve the quality of life for the patients and for the family. Again, I can't tell you how many people, families have come up to me when I've been out in the community or during fundraising or, wherever I come in contact with them, and they are so thankful for our hospice program. They're entering a period of anxiety and not quite sure what the future holds. And I can't stress enough that our hospice team are experts at what they do, and they provide education, they provide emotional support, they provide spiritual support. If wanted, they really lift the burden from the family and the patients, and they're constantly there making sure things are being met. So this is important philosophy about hospice. So hospice does not speed up or slow down the patient's dying process, but it provides comfort as the patient goes through the natural end of life. And unfortunately, there's some myths out there, and I'm going to talk about a few right now that people have regarding hospice that I've heard and that are kind of common. First of all, some people believe that hospice is only for the final days or weeks of life, and that's not true. In order to really benefit from our whole team member, our social workers, our clergy, the home health aides, the physicians, that's why Medicare says, 6 months is appropriate. Our team can come in and provide emotional support, really ease and nerves and just feelings of unknown about what's going to happen. I can't stress enough that they're experts at what they do. And like I said, so many family members have said, I was so thankful they came. I was so thankful that we had hospice. They made everything so much easier, so much more understandable. So it is not just for the final days. My advice to anyone would be, if you have questions about hospice, call our program. Again, we want to educate you guys on the wonderful service that we have, and call if you have any questions. Let's see, there's another. Okay, hospice is only for cancer patients. Only about half, maybe less than half of our patients are cancer patients. We see end-stage renal disease. We have, heart, end-stage heart, end-stage COPD, end-stage dementia. There's each diagnosis, that has sets. There's plenty of diagnoses out there other than cancer that our services see. So it's just not for cancer. Another thing that I've heard about hospice is that hospice hastens death by using morphine. So I've been a nurse for, I think it's 30 years this year. And morphine is one of the safest medications you can use. It's not, it's very safe. We've been using it for years. The reason it's so helpful, especially in hospice, is because it can control patient relief anxiety. It can help with shortness of breath, and we taper it to the patient's needs. And so hospice is a very safe medication. I know that some people, unfortunately, one of the problems hospice does have is that we don't get patients soon enough. So all of a sudden we have this patient who really is ready to die, and their anxiety and they're short of breath and they're in lots of pain. We get them into our program, we get them medicated, we get them comfortable, and then they can die peacefully. So again, I can't stress enough the importance of, if you think someone is appropriate for palliative care or hospice, give us a call. If you're not getting the answer that you want from, your primary care or anyone else out there, our office is always there to answer questions. Another myth that I've heard is that, once you're in hospice, you can't get out. That's not true. Hospice is your benefit. If, say, you enter hospice and 2 months down the road, you decide you want to seek curative treatment, we discharge you and you seek curative treatment. And say another 6 months down the road, when you decide you're done with aggressive treatment, you want to come back into hospice, we readmit you into hospice as long as you qualify. So it is your benefit. Most people, when they enter our hospice program, they're so thankful. And, we don't see many people wanting to be discharged. Like I say, it's their exploit. Did I go back? Let me see. I think I missed. Okay. Okay, so hospice services. We manage pain. We manage shortness of breath. We manage anxiety, depression, constipation. So those are kind of common signs and symptoms that we see in hospice. But there are many more. I mean, each disease process brings their own set of problems sometimes. So but these are common ones. The nurses go to the patient's home anywhere from daily to once a week to assess a patient and provide care. Nurse aides provide bath care 3 times a week. Again, that can be flexible. So, but we go wherever you call home. So if you're in a nursing home, yes, our nurse will go to that nursing home. Our aide will go to that nursing home. Same with the facility. Okay, so chaplain. You have a chaplain visit at least monthly or more often if you want it. I can't say enough good about our chaplains. So no matter what denomination, religious-wise you are, they're trained to provide spiritual support, regardless if you're a Christian or Muslim or atheist, and you have some spirituality issues, or you want to talk through something that requires or about your spirituality. They are fabulous, and they can come in and really diffuse the situation. I've seen it happen. It's a wonderful service. And then, of course, our social workers, a lot of the same things. I hear about them. They see our patients at least once a month and more often as needed. They also a lot of time with the emotional aspects of patients and families. So, but regardless, hospice is there to assist the patient with the emotional, the psychosocial, and the spiritual aspects of dying. And our chaplain and social work services are, do just that. Okay, so we typically, when you come into our hospice program, you're not going to get therapies. It's not skilled therapy like, what you get, if you, had a hip done and you go to a skilled nursing home to get a bunch of therapy. So the only time we would ever use if you would need help, like maybe we would bring a speech therapist in to assure that the patient's swallowing safely and they can actually, the patient and the family, different prompts and, what's best, intake for the patient as far as texture. So we would consult speech therapy on that. Sometimes we would do therapy if the patient needed a specialized wheelchair or the family just needed to instruct on how to safely transfer patients or their loved one. We would use therapy for situations like that, but not just you're not going to get a therapy consult on a mission like you do in skilled therapy. So they're really just to help a family member if they need it through, these issues that I just talked about. And another thing that is part of hospice is not part of palliative care is our bereavement services. So Albany Hospice has a fabulous bereavement program, but every hospice program is required to provide bereavement services, afterwards for our family and friends. Actually, our bereavement services is available to anyone, whether you used our hospice or not. You need help with grieving. If you don't think you're grieving healthy, we have certified grief counselors on staff that can help you through that. But we also have support groups that meet, and it's a wonderful service. If I don't know if anyone's ever been a part of a support group, but it can really help you through difficult times. Okay, so most of them have a hospice benefit, and so how they pay for it is it's called a global daily fee that is paid to hospice to cover everything provided. So we get one lump sum to pay for all your care. No matter what kind of care you have, we get one lump sum. This is important though. It does not cover room and board if you are staying at a nursing home. So if our hospice program is seeing a loved one in a nursing home, yes, it will cover all those things I talked about, medications, medical supplies, but it won't cover the room and board at a nursing home. Okay, that's the ability of the family. And that's exactly what the next phrase says. Oh, no, I'm sorry. So the hospice, so we have what's called, and our director of nursing at the Altman branch, she calls it a hospital for hospice patients. But we do have what's called Compassionate Care Center, and we're very blessed to have Compassionate Care Center. And it is, just like she said, it's a hospital for our hospice patients. So if you have a symptom at home that we can't get under control, no matter what we do, no matter what we try to resolve your symptoms, and we still can't get you comfortable, or whatever the situation is, we can't get it quite right, we bring you into Compassionate Care Center. And it's 24-hour care. The technical term is general inpatient level of care. But Compassionate Care Center is the only one, I believe, in Starr County. And like I said, it's a hospital for hospice patients. And again, that's their specialty. They're not going to send you to the emergency room. They're not going to do unnecessary tests. They're going to bring you in, and with their expertise, they're going to manage those symptoms that we haven't been able to manage at home. And then once you're managed, we send you back to your home. And again, that's called, the technical term is general inpatient level of care. It's our Compassionate Care Center. It's a beautiful place. If I've given tours before. I often say, I wish my office was out here. It's a beautiful place. If you're ever interested in touring it, please let me know. But it's a wonderful service that Alton has. Okay, so summary of palliative care. It's appropriate for anyone with a chronic illness to assist with symptom management. They provide disease education, and they really discuss goals of care. The patients can be seen in the hospital, the clinic, the office, nursing home, home settings, pretty much wherever they call home. The patient can still be seeking aggressive curative treatments for their illnesses and still be receiving palliative care. One thing I don't know if it was mentioned, you still keep your primary care physician, palliative care. Our palliative care physicians work along with your primary care physicians, but they remain your primary care physician. So hospice. So hospice is appropriate for patients felt to be in their last 6 months of life, or who have chosen comfort care and no longer desire hospitalization or emergency room visits. Care is given to the patient at the home, and the focus is on comfort and quality of life. And there was a question that came up about, what qualifies you for hospice, that they're familiar with, like the general signs and symptoms that you may be qualifying for hospice, such as frequent hospitalizations. Like I pointed out, all of a sudden traditional medical treatment isn't effective anymore. Weight loss. All of a sudden the patient can't take care of themselves. Declining nutritional status. They have multiple comorbidities. So not only do you have Parkinson's, but maybe you have, like I said, diabetes and frequent trips to the ED, frequent pneumonia. Those are kind of go along with most diagnoses, but each specific diagnosis, for instance, renal disease, they're going to have a separate, a lot of those, you're looking at decreased urine output of like maybe, 400 milliliters or less a day, or they've chosen not to go on dialysis. For heart disease, it could be end stage, stage 4 heart disease, and literally the patient at rest is at pain and discomfort. So there's different specific qualifications for each disease, like for renal, for pulmonary stuff. So it's really, like I said, when in doubt, just call hospice and ask them. The general ones, sure, those are kind of easy to pick out. They have, like I said earlier, the decline in ADL, weight loss, frequent hospitalizations, traditional medical treatment isn't helping. But then there's other specific ones too, depending on what disease process you have going on. Let's see. And I think that's it. Do we have questions?